My name is Shatina Ivy, and I'm a registered nurse pursuing a Bachelor of Science in Nursing at Florida State College in Jacksonville. I'd like to talk about the topic of the impact of self-management programs on African Americans diagnosed with type 2 diabetes. My PGOT question is, in African American adults diagnosed with type 2 diabetes, how does a chronic disease self-management program compared to no self-management program affect HbA1c levels within 6 months? I chose this topic because I work primarily with inmates of African descent who have been diagnosed with type 2 diabetes. One day while checking their glucose levels, I noticed that a lot of them were a little bit confused or concerned even about why their glucose levels were so high. They would say things like, "Oh, Miss Ivy, I eat really healthy. I drink a lot of orange juice and I eat a lot of the potatoes on my tray." And a lot of them just weren't familiar with what foods were high on the glycemic index. So I began to ask myself a few questions. How could I help my patients, and more importantly, what resources would be available to this group and that could impact them, especially targeting the specific population of African Americans. Well, this led me to begin to research some information about the plight of type 2 diabetes on the African American community. And I found two interesting articles written by Cadzo and others, and another by Spencer and others. And I was able to determined that the rates for chronic diseases such as type 2 diabetes are on a rise within the African American community, and almost 4.9 million African Americans are living with diabetes in the U.S. alone. Um, the reason why this is a problem is because the management of chronic disease is not just about going into the hospital every time your sugar is high, but a lot of how to manage it has to deal with the individual themselves. So if it particularly impacts one group of people, it's very important to think about ways to specifically help this community. So the articles that I found, Cadzo and others, and Spencer and others, they looked at what would help African Americans manage their type 2 chronic diabetes. Doing the research, they used what we call community health workers. And community health workers are people that live within the community themselves who have a shared cultural experience, but are also knowledgeable in the management of chronic diseases. This can be registered nurses. It could just be people within the community, with the churchgoers, but they can attend specific classes that will allow them to learn more about the disease. So you don't have to be a licensed health professional, just someone who's able to provide teachings on the management of chronic diseases. So what these researchers did was that they took a sample from a community with primarily African Americans, and they used community health workers to help teach the residents or the participants ways to help manage their diabetes. So, with that being said, they realized that the demand for community health workers through their research and through their experiment, they realized the impact that community health workers could do. So, for instance, The burden and prevalence of type 2 diabetes, it not only disproportionately affects African Americans, but African Americans also carry the higher burden of illness and mortality. With that being said, the demand for community health workers is so important. And as I stated earlier, nurses can act as community health workers, not just based on the fact that they're licensed, knowledgeable health professions, but they also have a specific tie to the community as well. Many nurses, sometimes you don't even realize that you're acting as a community health worker when you're putting on blood pressure checks for your church members or just within the community themselves. So the need for community health workers, people who have a shared cultural experience, who are aware of this, of what's unique about that culture, their ability to impact and help manage them in their, help manage whatever population or culture, there is a need for them in particular. A lot of times the community health workers within both studies, Cadzo and Spencer, they will accompany African Americans to the hospital. And what they would be able to do is translate the knowledge of the health provider and put it in terms of how it is for, or put it in layman's terms, and help the participants, primarily of African American descent, understand the things that the doctor was trying to say, trying to bridge that cultural gap. So, especially in Spencer's research, he noticed that in the groups that had community health workers provide the diabetes self-management education, the LDL levels of the intervention group had also improved after the 6-month follow-up. And in Cadzo's research, he noticed that the glucose levels had gone from 8.6% to 7.3%, and there was no change in the control group who did not have community health workers provide the diabetic self-management education. So you may be asking yourself, what can I do as a nurse who also acts as a community health worker? How, when I'm providing diabetic self-management education, how am I able to tailor it to where it's evidence-based, but it also is giving a cultural, being culturally aware? One way to do that is to stick with the clinical guidelines that have been produced by the American Diabetic Association. And one of those things is patient progress. It's very important to monitor the progress of your patient, meaning you do a baseline and then do a 6-month follow-up to see how is this patient progressing. Are their levels higher? Are they lower? Talk with the patient and making sure that what the information that you're disseminating is actually being effective. Another clinical guideline is to seek input from the external stakeholders. How can if they see something that's going on with the program, maybe you're not targeting the right people, maybe the information that you're providing is not applicable, maybe people aren't able to understand the information that you're providing. So just having an external input about what you're doing and the information that you're giving out, that may help as well. Also, another issue is access. Am I targeting the right population? Am I providing the right tools, the right educational follow-up for the population? And the next thing for clinical guidelines in terms of instructional staff is at least one person that's providing or overseeing the curriculum for the diabetic self-management needs to be a registered or a licensed professional, such as a registered nurse or a dietitian or someone that has knowledge of the disease process and a licensed and is also licensed. In terms of best practices, you definitely want to use evidence-based research. The American Diabetes Association publishes a lot of education that's backed in clinical research. Doing so just provides more validity to your program, and also in terms of reimbursement, a lot of programs, unless you use the clinical guidelines, won't reimburse you, such as Medicaid and Medicare. That's how they actually go about reimbursement. Also, you want to individualize the program. What works for one patient may not work well for the next patient. So it's really important to focus on the needs of the specific population, whether it's primarily an African American resident you're working with of the community or a Latino. It just depends. And even then it needs to be even more specific if you can tailor it to that. Another thing is providing accurate resources. Will your resources be perceived in a way that's not culturally exclusive? Will some literature may not take into may not take into account certain diets, and other things that can impact what people eat and how they self-care. So you just want to make sure that your education is culturally sound and things of that nature. So, in conclusion, African Americans who participate in self-management programs feel more empowered. They feel as though someone is there with them, especially in the doctor's office, that understands their concerns and maybe even their fears of Western medicine. But they also know that the person that's with them has an understanding of the medical profession, but more so also understands their disease process. Also noted was favorable changes in behavior. In Spencer's research, he noticed that the participants who had community health workers helping them with the management of their disease, a lot of them were doing more like things such as checking their shoes, insides of their soles, and testing the water that they put their feet in with thermometers. Those practices went up when they had community health workers present. And also, self-management programs can be effective in the management of lowering HbA1c levels, which is really important because this is a chronic illness, and in order to reduce acute exacerbations of it, it's really important to learn how to manage it and keep your numbers at a good level. So all of that together, with having a community health worker, can really not just empower people of vulnerable and underserved populations, but it has also been proven in some aspects how it can at least be favorable in helping them manage their disease process. Thank you for your time.